very famous endoscopic surgeon, Girish Datar from India. Girish Datar, welcome.
It's a great opportunity to be here in Ukraine. This is my second time in ISMIS, and it's a great pleasure always to be here. Thanks a lot for the invitation. Thanks a lot for all the hospitality that you have extended towards me during my travel, stay, and getting back to my own country. So, well, I've been given the job of talking about full endoscopic interbody fusion. Full endoscopic interbody fusion is not something new that we are trying to talk. Only thing is the technique has refined over a period of time, and we have been able to do it very successfully. We can predict the outcomes, we can predict the technique even in very bad degenerative spines, which also includes listhesis of grade 2 and grade 3. So too high listhesis may not be a good indication because you need a good soft tissue release before you actually do an interbody fusion. But grade 1, 2, and sometimes maybe 3, if you're confident enough, are good indications. So the concept of posterior interbody fusion, we know that interbody fusion can be performed through multiple routes. One is the posterior, one is the transforaminal route, which is called the OLLIF, or the transcambin fusion, and you have the oblique fusion, and you have the anterior fusion. The least minimally invasive fusions which are done through the oblique part, that is the OLLIF or the transcambin, and the posterior fusions, which we are well aware with the classical MIS TLIF, which is being done for now years and ages together. The endoscopic fusion is just the same kind of a surgery, just using the endoscope. So I would like to highlight that posterior fusions in spine, primarily TLIF, we have the posterior fusion, which is the posterior lumbar interbody fusion. We have the TLIF, which is knocking off the entire facet and putting in the cage. For endoscopy, that may not be required, so what we do is a transfacet fusion. So there are two accesses primarily. One is to either access the medial part of the facet joint or to access the dorsal part of the facet joint, depending upon what kind of a case that you are doing. If you are doing a primary case, that is, no surgery has been done on the segment before, then the medial joint line is a preferred technique because it's much faster. The dorsal facet joint is a preferred technique when there is already a lot of scarring, a previous surgery has already been performed, where through the joint, which is a safe corridor for you to get inside the area to do a fusion, where you don't have to fiddle around too much with the neural structures. So in the transfacet fusion, in the classical fusion, in a virgin case, you may have to take off the entire inferior articular process and just the horizontal component of the superior articular process. This means that we are going to retain the entire vertical component of the superior articular process, which ensures the attachment of lateral musculature, which also ensures that you have abundant blood supply, which will in turn translate to faster fusions. So why do we need to change? We need to change because of multiple reasons. One is access-related trauma. Now, access-related trauma is important because we are worried about adjacent segments. One is the stress riser that is created either proximally or distally because fusion of a segment. And on top of it, if you destroy the paraspinal musculature during your surgery, that causes a ischemic area or scarred area in the posterior part of the spine, which is going to cause a lot of adjacent segments. Ability to operate under a very clear field. You will see some endoscopic videos here. The field is so clear that you can practically identify not only the normal neurological structures, but you can also identify pathoanatomy. You can also identify anomalies, like you have a conjoint root or something like that, very clearly identifiable. Retraction becomes very easy because you are able to identify the structures very easily. You're able to visualize inside of the disc. With the conventional TLIF, we always presume that we have prepared the end plates for fusion. So what ensures a good fusion is a good fusion bed, lot of bone graft, and a good stabilization. This is what are the primary prerequisites for any kind of a fusion surgery. So with endoscopic fusion, you're able to visualize within the disc and to prepare a very good bed for fusion, that is the end plate preparation. And because the area is small, because the invasion in the muscle is small, you don't remove the posterior structures, the interspinous, the supraspinous, the ligaments on the lateral side. Only 1/4 of the corridor, which is primarily accessed. You have the patient who can be rehabilitated very fast and can be usually discharged 24 hours after the surgery. So, is endoscopic interbody fusion feasible? Do we have so much of space? Now, if you look into different kinds of studies that have been done through the foramen, we need to understand that the Camden's triangle is actually not a triangle. It's a prism. It's a three-dimensional structure. With the prism being there in unretracted neural structure or the anatomy, you have already abundant space from the medial pedicular line to the lateral pedicular line. The exiting route, which is usually at a problem, and the traversing route medially is far much away from the entire area. So you have a safe corridor between the two pedicles, that is the superior and the inferior, and the medial and the lateral pedicular wall. And this ensures that a feasibility of putting a large size cage is possible. So you can see the amount of area that is available so that you can put it. Now, I'll take an illustrative example of a patient. Here you can see a 60 years male who is a medical doctor with bilateral thigh lower limb pain, right more than left, 50 feet claudication, back was 7, right leg pain was 7. Neurology apart from that was normal. Patient is a diabetic, non-hypertensive, has undergone a CABG. You can see that the dynamic x-rays are showing instability. There is a grade 1 listhesis which is contributing to the whole symptomatology of the patient. You can see the axial sections of the MRI. There is a bilateral lateral recess stenosis, quite severe stenosis, overhanging of the facets, causing compression of the neural structures. And if you have a listhesis on top of it, this is going to be really severe. So let's take this representative case, and then I will discuss how the surgery proceeds. So the classical position and equipment is required. You have the patient in the prone position with the bolster underneath the pelvis, well supported, and underneath the chest. Flexion in the knee helps relax the hamstring muscles. That will also help relax the paraspinal musculatures. A 9 inches high frequency image intensifier is necessary. 6 inches may not be sufficient because your lateral images may not be very good. Anesthesia, I prefer to do it under general anesthesia, but you can prefer to do it under regional anesthesia as well. So there are many people who are doing it under regional, but I prefer to do it under GA. A complete endoscopic tower with a high-speed drill, radio frequency generators, plasma, and a few irrigation pumps. So I do not rely on gravity because I need to exactly know what is the pressure. So I always use a pump. The pressure that is usually 30 millimeters of mercury at a rate of 300 ml per minute. This is the rate that I use. So we haven't had any kind of fluid relation or pump related or irrigation related problems in the last 15 years because of the use of the pump. So the important thing is targeting. So what is different from a classical stenosis surgery? The stenosis surgery, you just go to the level segment. You really don't matter. It doesn't really matter whether you are in line with the disc or not, because you're going to work in the spinal canal primarily. But in an interbody fusion, you not only work in the spinal canal, but you're going to also work inside the disc. So your trajectory has to be absolutely parallel to the disc. If it is oblique to the disc, you can have a lot of end plate injuries, or you can have fracture of the end plate, bony end plate, when you're putting in the cage. So it is necessary that you are in line with the disc. This is the only difference with the trajectory. Apart from that, you can either enter at the medial pedicular line or mid pedicular line, depending upon how much is the interpedicular distance, what kind of cage you are using, and has the patient undergone a previous surgery or not. So these are the factors which will tell you where to enter in the spinal canal. So here's a short video. You can see targeting. So I usually enter midway between medial pedicular and midline. So parallel to the disc. So the first thing that we do is an extraspinal clearance. I need to identify the first consistent anatomical landmark, that is the spinolaminar junction. I prefer to use a plasma here. and strip off the entire soft tissues from the bone. Now this is necessary because when I'm going to harvest or when I'm going to remove this bone, the same bone will be utilized for interbody packing. You will use it as a bone graft. So you remove the soft tissue right inside, because to get a soft tissue out from the bone with a small piece is extremely difficult. So it is better to remove the entire soft tissue from the bone before you actually get the part of the bone chipped out and get outside. Next is going to be the cranial laminotomy. The steps are very, very similar to what we do with open. So once I see, I can use the burr. Now the burr is useful for two reasons. One is to define the bony margins. Second, most important, it takes away the whole soft tissue from the bone. So you have a nice raw bone which can be utilized for interbody graft. So very lightly you move your burr from the spinolaminar junction, the base of the spinous process, cranial lamina, coming all the way to the inferior articular process, reaching the tip of the inferior articular process. So once you have done that, then it is the job of the kerrison, or you can use an osteotome, whatever fancies you, either an osteotome or a kerrison, and start taking off bone. The concept is to take off bone. So do not detach the ligamentum flavum at this point in the surgery. The ligamentum flavum remains intact till the entire bony work is over. That will ensure two things: safety, a corridor, that will, the instruments do not injure the dura, and second thing, you don't push inadvertently the fluid in the epidural space. Also reduces the amount of bleeding. So you keep on taking bone normally because you want to take off the entire inferior articular process. So you identify the inferior tip of the inferior articular process, which usually is on the caudal lamina. The moment you take off this tip of the inferior articular process, you start seeing the caudal lamina. You can see the part of the superior articular process inside because there has been a facet trophism and there is a rotational element, the lateral recess stenosis, which is seen there. The next is going to be the removal of the entire inferior articular process. You can do it with the kerrison, it just takes more time. I prefer to use the osteotome, start chipping off the inferior articular process from caudal to cranial. Now I reach, how cranial? I reach the inferior part of the end plate of the cranial vertebra and don't go beyond that. The reason is this part of the pars interarticularis protects the exiting root. So I do not remove the covering of the bone over the exiting root and leave it the way it is till I put the cage. Once I put the cage inside, then I take off that part of the bone. So I start using this to chip out bone. So sequentially, osteotomy. Once you have removed the part of the pars, this part of the bone which you see on the top, I leave it behind because that is protecting the exiting root. Now I have to take care of only one root, which is the traversing root. So I come to the inferior part. So you can see the entire thing moving now. So contralateral decompression. So the success of fusion surgery also a lot depends upon how well you are able to decompress. So contralateral decompression is primarily splitting the ligamentum flavum or stripping off the ligamentum flavum from underneath the capsule, underneath the lamina, cranial lamina, and you can go, or from the caudal lamina. So it depends upon how comfortable you are, either the cranial or the caudal. Just follow the caudal lamina, it will lead you to the contralateral side, also lead you to the superior articular process and the joint. If you want to do a contralateral facetectomy at this point of time, this is the time that you can do a facetectomy, that obliquely you can place your osteotome and take it off. So use a drill as much as necessary just to shave off whatever is required. Another best tool to use here is a curved osteotome. If you have an osteotome, it is very easy with the osteotome because osteotome is much safer than using a drill. It's also cost effective because the drill requires replacement again and again once it gets blunt. So an osteotome is a wonderful tool for you to remove bone from the contralateral side. So you can see this part of the ligamentum flavum which I am separating from the base of the spinous process, and you go below, you completely separate it to the from the caudal lamina, lamina on the opposite side. And you can use bone, or you can use a drill, you can use an osteotome to just do a sublaminoplasty so that you create a lot of room there. So again, you're separating, you're going ahead. So once you go, you directly land on the superior articular process, because what you're working on is right now lamina, which ends into the inferior articular process. So the moment you take off the medial margin of the inferior articular process, you are on the superior articular process, or the joint on the contralateral side. Once you identify the medial margin of superior articular process, nibbling off the superior articular process is going to completely decompress the lateral recess on the contralateral side. So ipsilateral decompression. So once contralateral is over, then you start decompressing the ipsilateral side. You know this is the superior articular process. This is part of the cranial lamina. You need to create a nice corridor so that your cage does not have a hindrance when it is going inside. So it does not move here and there. So you create a nice corridor taking off a part of the cranial lamina. So sometimes you encounter bleeding at this place. There are a couple of ways to handle with the bleeding. Diamond burr, maybe you can just press it with the foot plate of your punch. Most of the times it is sufficient. You dissect out the deep layer of the ligamentum flavum from the superior articular process, and then you can use an osteotome, or you can use a Kerrison rounger to take off this part of the bone very successfully. Step by step, start going caudally from cranial onwards to the caudal lamina. So you'll go medial to the pedicle and the caudal lamina, where the important compression element is there. So you need to decompress the traversing root completely in the middle zone of the lateral recess. So you can start seeing, this is detachment of the ligamentum flavum caudally. You start seeing the thecal sac. You can appreciate the vision that you have when you're doing the decompression. Absolutely very clear. Nothing there. There's no ambiguity. There's no guesswork here. Absolutely, you can see each and every aspect of it. The bleeding is absolutely not there. So once the ligamentum flavum completely detaches, you know there is a midline raphe. You have detached the ligamentum flavum from cranial, medially from the superior articular process, caudally from the caudal lamina. So every point of time you can use your plasma generator. So once the ligamentum flavum opens up the epidural space, it has to be at a lower power. So now is you do a removal of the ligamentum flavum. By and large, since you have detached it from all the sides, it comes out as one single piece. So you try and see that there are no adhesions. So use the foot plate to just move your Kerrison cranial caudal, and then start taking off ligamentum flavum more laterally from the lateral recess and the spinal canal. So you can do a bilateral removal of the ligamentum flavum. So it's all loose. It's all loose now, so you just directly take it off. Confirm the decompression, identify the neurological structures ipsilaterally and contralaterally. Confirm the mobility of your nerve root very well. If there are adhesions, you need to do an adhesiolysis. Then is going to be preparation of the cage entry site, that is between the two pedicles. I normally get inside at the medial pedicular line. So you can prepare with the help of the plasma wand to secure all the bleeders here. You have a connecting vein which comes from the extraforaminal region into the spinal canal, which is an important element which needs to be taken care of. So once you get this part of the whole thing dissected out, you can just turn the sleeve to protect the traversing route medially. You see the traversing route is now completely protected, and now you can use your mechanical shavers. And once the shavers are used, you can manually go inside the disc to visualize and remove all the remaining articular cartilage to see the anterior part, that is the anterior annulus. So by and large, you are able to prepare about 60% of the end plate. 100% is not possible because the contralateral dorsal aspect is not accessible. If you have some curved tools, like you have a shaver now with a curved shaver, you can also do the contralateral side. So, but you can ensure a nice end plate preparation on both the sides. Once you see this kind of end plate preparation, you may just have to now put in the bone graft. So size your space very well. Size it well. So I usually use a size above the size that I size it. And the cage is implanted after using a small retractor to retract the traversing route. Here I don't have to worry about the exiting route because it is still covered by bone and ligamentum flavum. Now in some cases where you have compression of the exiting route, you may be required to do decompression of the exiting route. So you start the decompression of the exiting route from above the roof of the axilla and the cranially, and just follow it laterally. So the moment I start taking off bone and ligamentum flavum together, the exiting route comes into vision. So this is part of the ligamentum flavum which is attached to the inferior margin of the cranial pedicle. So rather than cutting the ligamentum flavum, I prefer to strip it directly so that it comes out. You can see a nice exiting route here. There's not much compression here. From within the canal into the foramen to the extraforaminal region, you can decompress the entire exiting route. Confirm the position of your and then augment the entire thing with the posterior instrumentation, which is percutaneous pedicle screws. So here we have used 11-degree lordotic cage. I prefer to put the cage more anteriorly. You can put two cages, one oblique, one straight. You can put a banana cage. Whatever you think is the best, you can use it. Now, you can also use an olive cage, but you cannot put it through the same. You have to have one more posterior lateral axis after you have done your complete facetectomy. So you can put a real large size cage in the patients. Thanks a lot for your patient listening. Thanks a lot for the opportunity.